Imagine you have a lung cancer patient. They've been fighting this incredibly grueling battle, right? And to give them the absolute best chance, their oncology team gives them this powerful double punch.
Right, the combination therapy.
Exactly. Immunotherapy and thoracic radiation therapy. And, for a while it's working, the tumor is shrinking, but then suddenly the patient just crashes.
They develop this severe hacking cough.
Yeah, dangerously short of breath. They get rushed to the hospital, and a chest CT scan shows this profound diffuse inflammation just all across the lung tissue.
It's a terrifying scenario.
It really is, because now the attending doctor is standing at the foot of the bed facing literally a life or death decision. Is this acute lung inflammation caused by the immunotherapy drug, or is it a delayed reaction to the radiation?
And the stakes are impossibly high.
Right, because if the doctor guesses wrong and permanently stops the life-saving cancer drug for no reason, the tumor comes back. But if they keep giving the immunotherapy, and that's the very thing destroying the lung well, the patient suffers fatal respiratory failure.
It's an incredibly high-stakes medical tightrope walk. And, until very recently, doctors have been walking that tightrope completely blindfolded.
Just totally guessing.
Exactly. Forced to make a clinical guess based on circumstantial evidence. But there's this groundbreaking 2026 paper by Zhu and colleagues in the journal Med that just removed the blindfold.
Oh, it's so cool.
They didn't just look at the lungs. They actually looked at the private molecular diaries of the individual cells causing the damage to figure out exactly who pulled the trigger.
Okay, let's unpack this. Because to really grasp what Zhu's team did, we need to understand our two main suspects here.
Right, the two treatments.
Yeah, so the first suspect is the immunotherapy, specifically immune checkpoint inhibitors, or ICIs. Now, cancer cells are notorious for exploiting checkpoint proteins like PD-L1.
They use them like a shield.
Exactly. When a patrolling immune T cell comes along, the tumor cell shows this PD-L1 protein, which essentially hits the brakes on the T cell, stops it from attacking.
And that's where the checkpoint inhibitors come in. They don't supercharge the immune system. They literally just cut those brake lines. By blocking that PD-L1 interaction, the T cells can't be stopped anymore. They recognize the tumor and they attack.
Which brings us to the second suspect, thoracic radiation therapy, or TRT. And instead of altering immune signals, TRT is just highly localized ionizing radiation.
That's targeted energy.
Yeah, it's like a lightning bolt designed to physically shatter the DNA of the lung tumor.
And both of these modalities are highly effective.
Yeah.
But unfortunately, both leave massive collateral damage in their wake.
Which causes pneumonitis.
Exactly. Severe inflammation. The delicate architecture of the lung, specifically the alveoli where gas exchange happens, it just gets compromised by this aggressive influx of fluid and immune cells.
And to figure out what's happening, doctors usually do a bronchoalveolar lavage, right? A BALF.
Yes, essentially a lung wash.
Yeah. They guide a scope down there, introduce fluid, and suction it back out to collect the local cells. But here is the real diagnostic nightmare.
They look exactly the same.
Right. Whether it's checkpoint inhibitor pneumonitis CIP or radiation pneumonitis RP, the lung wash looks virtually identical under a microscope.
They both show this classic lymphocytic pattern. The fluid is just swarming with white blood cells.
It's like ICIs are like giving the entire police force endless energy drinks, while TRT is like setting off a targeted explosive. Both leave a completely chaotic, inflamed crime scene in the lung.
That's a great way to put it. Looking at standard x-rays or even basic flow cytometry from the lung wash, you just can't tell if these immune cells are responding to the systemic removal of their brakes or if they're just swarming a site of radiation trauma.
So doctors historically just had to rely on exclusionary criteria, like guessing based on the timeline or the shape of the inflammation on the scan.
Which is, at its core, an educated guessing game.
Oh. Yeah, so just think about this for a second. If you're the doctor standing at that bedside, your patient is crashing, and all your tests just show a generic swarm of immune cells. How would you feel having to make a guess that could permanently stop a patient's life-saving cancer drug?
It's the kind of scenario that keeps oncologists awake at night.
Seriously.
And it's exactly why the Zhu team brought in high-dimensional single-cell technology to find a biological fingerprint. They used tRNA-seq and STT-CR-seq on the lavage fluid.
And single-cell RNA sequencing, we see it everywhere now, but the distinction is so vital here. It used to be bulk sequencing, like putting a whole bowl of fruit in a blender and trying to figure out the recipe by tasting the smoothie.
Right. You taste strawberries, but the details of one specific blueberry are lost.
Exactly. But scRNA-seq isolates every single individual cell from that lung wash and reads its RNA. It's like reading the private diary of what that specific cell is doing right at that microsecond.
And they paired it with scTCR-seq. The TCR is the T-cell receptor. It's the unique ID badge on every T cell.
So they're doing lineage tracing. They can see exactly which clone army every single cell came from.
Exactly. And the study design was meticulous. They looked at 7 CIP patients, low-grade ones who responded to steroids, 6 RP patients, and 6 healthy controls.
And here's where it gets really interesting. When they looked at the single-cell data for the immunotherapy patients, they found this massive accumulation of CD8 plus exhausted T cells, or TEXs.
What's fascinating here is what exhausted actually means in this context.
Wait, yeah, let me push back on that. Because, I mean, if a cell is exhausted, shouldn't it just die off, like undergo apoptosis and get cleared out? Why is a burnt-out cell causing life-threatening lung damage?
It's a phenomenal question because exhaustion is honestly a terrible name for it. The cell is not peacefully resting.
No, it's not.
No, exhaustion is a distinct state of chronic overstimulation.
Mm-hmm.
Because the immunotherapy cut the brake lines, these killer cells have been fighting without pause. Their internal programming becomes totally dysfunctional.
So their normal cell death mechanisms fail.
Exactly. They lose the ability to undergo apoptosis.
So they become like immortal, erratic zombies.
In a sense, yes. They are trapped in this terminal dysfunction, but they keep spontaneously releasing highly toxic chemicals like granzyme B into the lung. Their fingers just jammed on the trigger.
Wow. So we're reading their transcriptomic diaries and seeing that the lung is packed with these zombie T cells. Can you visualize that? These exhausted immune cells, unable to die, just constantly firing toxic signals into healthy tissue.
And tracing where they came from is the key.
Right. What happens when we check their ID badges? But first, let's do a quick recap. 5-minute bullet summary time. Number 1, the dilemma.
Both immunotherapy and thoracic radiation cause severe, identical-looking pneumonitis.
Number 2, the method. Doctors do a BALF, a lung wash, to sample the area.
Number 3, the tech. Moving from smoothie bulk sequencing to single-cell reading of diaries and ID badges.
And number 4, the discovery. Immunotherapy pneumonitis is packed with exhausted T cells that are overstimulated and leaking toxic molecules.
Perfect. So tracing their origin is where this paper completely alters our understanding. They use trajectory analysis to follow these exhausted cells backwards.
And this is where the two identical-looking diseases totally diverge.
Completely.
It is entirely a tale of two pathways. Let's break down the biological origin of each, and I'm going to give you 2 mnemonics to lock this in. So for the CIP, the immunotherapy pneumonitis, those exhausted cells came from a lineage with high expression of ZNF683.
Yes, ZNF683hi CD8 plus T cells.
Yeah.
Biologically, these are tissue-resident memory cells.
Chimbochirms.
Exactly. They are incredibly specialized. They don't circulate in the blood. They embed themselves permanently inside barrier tissues, like the lungs, their frontline guards.
Okay, so here's the mnemonic. Think of ZNF as the zone native force. They are the local bouncers who live permanently in the local lung zone. And their diaries showed they are driven by the TNF-alpha pathway, right?
Yes, tumor necrosis factor alpha. It's a potent cytokine that amplifies local inflammation.
Okay, now contrast that with radiation pneumonitis.
Total opposite. When they traced the cells in RP patients, they found zero connection to those local ZNF bouncers. The exhausted cells from radiation injury expressed high levels of GZMK.
So GZMKhi cells, and these are peripherally derived effector cells, meaning they come from the blood circulation.
Right.
So your second mnemonic, think of GZMK as the global zone mobile cops. These are the circulating riot police. The radiation damages the lung, and these mobile cops are recruited from the bloodstream, fled into the lung, and react.
And their communication network is fundamentally different. The GZMK mobile cops use the IFN alpha interferon alpha signaling pathway.
Which is more about systemic recruitment, right?
Exactly. And the paper notes a crucial detail. Expression of ZNF683 and GZMK is mutually exclusive.
Meaning a cell is either a local bouncer or a mobile cop. It cannot be both.
Never both. Which gives us our differentiator. You have a patient crashing, lungs full of white blood cells. Standard tests say it's the same disease, but molecularly.
CIP is the awakening of local tissue bouncers using TNF-alpha. And RP is a vascular invasion of mobile COPs using IFN-alpha.
Exactly.
And that pathway difference is massive for treatments. Because if RP is driven by IFN-alpha, we might be able to use existing drugs, like lupus treatments, to calm down the radiation injury without stopping the patient's cancer immunity.
Precisely.
So picture the local bouncers versus the mobile riot police. Which group do you think is harder to calm down once an immunotherapy drug takes away their brakes?
Well, that's the exact biological question the zoo team had to turn into a clinical tool.
Yeah.
Because, a doctor in the ER can't run a multi-week trajectory analysis on a crashing patient.
Right. They need answers now.
So the researchers distill this massive data into a mathematical grading algorithm using 3 specific cellular ratios from the lung wash.
Okay, hold on. Let's look closely at this algorithm. Biologically, what are we actually measuring? Ratio 1 is the CD8 plus killer T cells compared to CD4 plus helper T cells. Why that?
It establishes the baseline. A skewed CD8 to CD4 ratio tells the doctor there's a massive unchecked expansion of killer cells dominating the area.
Okay, makes sense. Then ratio 2 compares the exhausted CD8 plus cells to the total pool of CD8 plus cells.
Right, the burnout fraction.
Yeah.
Out of all the killer cells, what percentage has turned into those erratic, toxic zombies?
Got it. And then ratio 3 is the ultimate differentiator. It measures the ZNF683 local bouncers against the total exhausted cells.
Exactly. If ratio 3 is high, it points definitively to CIP. The local bouncers did the damage. If it's low, the damage was driven by GZMK mobile COPs pointing to RP.
And to prove this actually works, they tested it on 5 incredibly tricky patients, the ICI-RP validation cohort.
These patients had received both treatments and developed severe pneumonitis.
The ultimate nightmare scenario. Standard tests weren't definitive enough to risk their lives, so they ran the lung fluid through this new 3-ratio algorithm.
And they even validated against an external public data set to prove their math wasn't biased.
The results were undeniable, right? The algorithm proved, at a molecular level, that all 5 patients had radiation pneumonitis. The local bouncers were barely involved.
And if we connect this to the bigger picture, the clinical ramifications are staggering. Because the doctors had molecular proof the immunotherapy wasn't the culprit, they safely rechallenged the patients.
Rechallenge meaning they restarted the cancer drug.
Yes. For 3 of the patients, once the acute inflammation went down, they went right back on immunotherapy. 0 recurrence over 8 months.
Wow.
And for the other 2 with milder symptoms, they didn't even interrupt the treatment.
That is just... It's the literal definition of precision medicine. We aren't just looking at a blurry X-ray anymore.
Exactly.
How incredible is it that a 3-step math equation from a lung wash can give a doctor the confidence to restart a life-saving drug? Let's do a really quick recap of that.
First, the 2 origins. CIP is the local bouncers on TNF-alpha. RP is the mobile COPs on IFN-alpha.
Second, the algorithm. 3 ratios based on the CD8 balance, the burnout fraction, and the local bouncer presence.
Third, clinical validation on 5 complex patients proved it was RP.
And finally, saving lives. Armed with that proof, doctors restarted the primary cancer therapy safely.
It's just phenomenal work.
So what does this all mean? Why should you care about ZNF683 versus GZMK, even if you aren't an oncologist?
Because this is shifting how we interact with human biology. We are interrogating single cells to dictate systemic cures.
This raises an important question, though, and the authors tackle it brilliantly. The implications go way beyond lung cancer. We just talked about how these local bouncer cells wake up and cause lung toxicity.
Right.
Immunology is finding similar CD8 plus resident memory populations driving severe autoimmune issues in entirely different organs.
Oh, because the checkpoint inhibitor cuts the brake line systemically. It goes everywhere.
Exactly. So we see these local bouncers causing severe colitis in the gut or extreme rashes on the skin. It leads to this unsettling hypothesis. Are our organs effectively hiding immune sleeper agents? Wait, really? It implies our lungs, our skin, our gut, they're like cellular archives holding on to the memory of past microscopic battles.
Yes. They're populated by local bouncers who've been quietly embedded there for years, just held in check by regulatory brakes. And when a drug removes those brakes to fight a tumor, it inadvertently wakes up every sleeper agent in the body.
Oh, wow.
It begs a profound question. Could this devastating lung injury actually just be collateral damage? Just the crossfire from a hyperactive, beneficial anti-tumor response that happened to wake up the lung's memory banks?
That is a wild concept to wrap your head around. The very cells quietly keeping you healthy right now could destroy your lungs if your immune brakes are ever removed. Think about that the next time you hear about a severe drug side effect. Are you just reacting to a chemical, Or is that medicine waking up a localized biological memory, a dormant cellular army that you didn't even know you were carrying? Keep digging, keep questioning the mechanisms, and we'll catch you on the next deep dive.